And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Good afternoon, everyone. I would like to extend a very warm welcome to you all to the PATA Real webinar, which is part of the PATA 2023 Summit. I can't believe we're on our last day of the summit already. It's gone too quickly. We hope that you've enjoyed the last few days, and especially today, which we particularly dedicated to all our sessions to advance HIV disease. I'm Agnes Ronan. I'm the head of programs at PATA, and I'll be your chair for this session. So before we delve in, just a reminder for those who are familiar with REAL and for those who are not familiar with REAL, I'll just tell you a little bit about what PATA REAL webinars are about. Our webinars are a platform that we've created for frontline health providers to present real clinical cases to a panel of experts so that they can engage with the experts and receive feedback on what they have done well or could have done better or differently. So this platform really creates a much needed opportunity for health providers to learn from real cases versus theory alone, which we all know we often find overwhelming. So the purpose of our webinars are for us to learn from real cases that we see on the front line. So the acronym itself stands for, can I please have the next slide? The acronym itself stands for the review of cases that health providers see on the front line, engaging peers, and sharing of cases that they may have found either challenging or think others could learn from, and accessing expert advice from our expert clinicians, and lastly, learning lessons together from each other's experiences. I must, however, emphasize that the REAL is not just an acronym. For us, it's about real cases seen and presented by real health providers. So I want that to make sure that that's clear what the REAL stands for. So today I am joined by a panel of experts on advanced HIV disease. The first two are our regular panelists. You'll be familiar with them. First, I have Dr. Nandita Sugadi, who you've already heard from this morning's session, in the prime session. Dr. Sugadi is a pediatrician. She consults with WHO on pediatric treatment and guidelines. She's the chair of PATA's Technical Advisory Panel and also PATA on the PATA board. She's joining us this morning from New York, so quite early for her. Thank you for joining so early, Dr. Sugadi. Our second panelist is Bahati Kasimonje. Bahati is a clinical psychologist from Newlands Clinic in Zimbabwe. She specializes in providing comprehensive psychological support to diverse populations, including young people in their diversity, young people living with HIV, cancer patients, and key populations. And then our third panelist, we are very honored today to have Prof. Akamnu Alani Sulaiman from Nigeria. Prof. Sulaiman specializes in, and now I have to read this carefully because it's a lot of big words, specializes in hematology and transfusion medicine at the University of Lagos. He has a special interest in immunohematology, hemato-oncology, and HIV medicine. He also chairs the National Task Team on antiretroviral therapy in Nigeria. So that's our panelists. Our cases for today are being presented by Dr. Puri Gonzalez. Dr. Puri, if you could come on. Dr. Gonzalez, if you could put your camera on so our audience can see you. Dr. Puri's cases are going to be pre-recorded, so you won't have a chance to see her, which is why I'm asking her to come on screen now. Dr. Gonzalez is PATA's country representative from Mozambique. Her interests and experience are in advanced HIV medicine and related diseases, particularly in pediatrics and PMTCT. And most notably, and I have to emphasize this, she is very passionate about mentoring frontline healthcare providers and providing on-the-job skills building, which is what she does for us in our breakthrough partnership in Mozambique. So thank you, Puri. So that's introductions done. During this session, I do encourage you to ask questions in the Q&A box. Your questions will make the learning even richer for everyone else. So please do, when you ask your questions, please do let us your name and your email address in case we're not able to get back to you during the session. So today, during the course of the day, as I said, the whole day has been dedicated to advanced HIV disease. And we heard a lot about AHD, unpacking of the guidelines and the strategies for treating children and adolescents, as well as care and support in the community. Now we're going to get a little bit more practical and engage with real cases that we see on the ground to understand how some of these guidelines and strategies unfold on the front line with all its realities and the challenges that we are confronted with every day. And I'm sure we will all have something to take away from these discussions. So again, I encourage you to ask questions so that you can learn from the cases. The platform, I think more importantly for us, the platform also provides an opportunity to have those who write the guidelines for us in the audience, and I know we've got some of them in the audience, to hear from us on what works and what does not work, and some of the challenges that we face implementing on the ground. Just this morning, I heard someone in the prime session asking about CD4 count. What about CD4 count? Because the guidelines are telling us about CD4 count, and yet many countries do not have access to CD4 count. So this is an opportunity to engage with those who craft the guidelines for us and hear what advice they have to give us. And I have to say that that's something that we as PATA are very, very proud of, the fact that we can bring these important people who write our guidance to hear directly from our experiences and not via some document or some report. So as PATA, we're very proud to provide you with that platform as frontline health providers. So before we delve in, next slide, please. I would like to thank Dr. Lisa Frigati from Tygerberg Hospital, who specially presented our cases. You will see that both cases highlight some of the key takeaway lessons on advanced HIV disease. So hopefully you'll find your one key takeaway in the cases. So now I will hand over to Dr. Gonzalez. She will present the cases. They are all both pre-recorded. After Puri has presented the first case, our panelists will jump in. We'll start off with Prof. Sulaiman. He will give his remarks, and then Dr. Sugadi will jump in, and then Bahati will come in with the psychosocial component. And I'm sure you all agree with me that that's really critical, especially if you were in our prime session this morning and you listen to Anna Sango's talk, you will understand the importance of making sure that we have a psychologist on the platform to add the additional comments or remarks that are needed on each case. So we're going to jump straight in, and I'll hand over to Dr. Puri's recording, case number 1. Thank you.
Good morning, good afternoon, everybody. As Agnes said, today I'm going to present the clinical case. My name is Puri Gonzalez. I'm a medical doctor. I'm based in Mozambique, and I'm working in the Breakthrough Partnership as PATA manager. We are going to start with the first case. We have a child of 4-month-old receiving a hospital casualty. The medical history: we have a 4-month-old male present at the emergency room with 2 days of history of cough, blocked nose, and fast breathing. In the physical examination, he was a febrile of admission. Oxygen saturation was 96% in room air, but he had moderate respiratory distress with chest retraction and tachypnea. The temperature was 37.4, BP 80/5, BP 80/50, heart rate 176 beats per minute, respiratory rate 62 breaths per minute. The weight was 4.5 kilograms, and the weight at birth 2.8 kilograms. On the auscultation of the lung, revealed crackle bilaterally. The abdomen was soft to palpation with no sign of rigidity or tenderness. The hepatosplenomegalia was not. The family background: we have the mother report that all paper related with the baby, the child health card, and the delivery information was missing during when they moved to another house. The mother said that the child born before arrival, and the mom booked late in pregnancy. The mother didn't say anything about the HIV status. Both parents are employees, and they are reliant on state social grant. The child has 2 siblings at home, under 10, and the mother said that they don't know about the HIV status. The team did a chest X-ray. As you can see here, the child has a bilateral pneumonia. Then he was admitted and managed for severe pneumonia. And the initial treatment regimen include ampicillin and gentamicin. Right after, the HIV rapid test of the mother came back positive. The team decided to collect a HIV PCR. With a strong clinical suspicion of a presumptive HIV diagnosis, the child continued with AMPI and gentamicin, but the team decided to add high dose of cotrimoxazole and prednisone, covering for a pneumocystis gyrovecii, and also ganciclovir, thinking in cytomegalovirus. After 20 hours of admission, he deteriorated in ward, was intubated and ventilated for 4 days. Then 2 days CPAP, then nasal bronch oxygen. After 6 days in intensive care unit, he was transferred back to work. Baby has improved clinically, feeding well, well hydrated, no respiratory distress anymore, and saturating well on room air. Heart rate 140 beats per minute, normal for his age. The mother stated that the child was not in contact with someone that was coughing or sick. But the additional laboratory tests were done. Gene spared on feces and TB in urine came negative. The child today completed 9 days of antibiotic. We want to highlight the key challenge and lesson on this child. The first one is the early diagnosis of difficult to reach women and infants. Second one, access to non-invasive ventilation like CPAP. Treatment, access to valanciclovir and steroids. And the last one, often enabled to make a definitive diagnosis of pneumocystis jirovecii pneumonia, but treat for polymicrobial pneumonia. This is our first case. I will ask to add some questions for our expert. How will you manage this child further? When should we start on ART? Should we wait for the PCR results? Our second question, does this child have advanced HIV disease? The third question, what strategies could have prevented this child from becoming so ill? And the last one, what option do you have if the child has low saturation? Thank you very much.
And I am going to hand this straight to our panelists, Prof. Akamnu, I think, or Nandita. I think it was Prof. Sulaiman first, right? Yeah. Please fire away, Prof.
Thank you very much, Dr. Puri, for successful management of this 4-month-old baby. If I can recount the major findings at presentation, this baby was just tachypneic, as respiratory embarrassment, and mild rise of body temperature. And it was very good to have suspected that this baby may have a pneumonia, which in fact your chest X-ray eventually confirmed because of the so-called hair bronchogram that was found. However, the major problem here is that there's nothing to suggest to us that the presentation of this child may have HIV infection as an underlying problem. And that is because you have not been able to note that the mother was HIV infected, meaning that whatever is our practice in every antenatal care services today, all pregnant women should be offered HIV testing. If this woman had had an HIV test done during pregnancy, we will not be at a loss as to whether a presentation has an HIV infection as a major problem. Now, this child was started on a combination of antibiotics and antiviral agents. I guess that was also very smart of you, because when a child has a respiratory embarrassment or a pneumonia, it may be a bacterial pneumonia, it may also be a viral pneumonia, and to have suspected the very common viral agent as a cause of pneumonia was very smart on your part. But what happens after you started this treatment is that 24 hours later, rather than the child improving, it deteriorated. That now suggested to us that this child truly may have what we call AIDS-defining illnesses, And on top of the age-defining illnesses that anyone should think of in a 4-month-old child that is affecting the lungs, is good to think of TB, which were excluded. Is good to think of what we call lymphoid interstitial pneumonitis. It is good to think of pneumocystis jirovecii pneumonia. And I guess that may have been suspected if this child's oxygen saturation at presentation was less than 96%, because one clinical indicator of pneumocystis jirovecii pneumonia is that that organism induces production of very thick mucus that occupies the space between the alveoli and the underlying capillaries, so that oxygen does not pass truly from the alveoli into the capillary. So what we tend to see, if that infection was truly that of pneumocystis jirovecii pneumonia, we tend to see very low SpO2 in the range of 91, 92%. And by the time it's coming down to below 90%, it's very severe situation. But in this child, at presentation, we are told what was the oxygen saturation. But when it deteriorated, we were silent about what's the oxygen saturation. But I guess the oxygen saturation must have declined so much that it required intensive care. And that intensive care that you gave actually salvaged this individual. I am also very happy that you suspected the pneumocystis jirovecii pneumonia, because you could have just developed right there under your watch on admission. If you didn't have access to intensive care for that child, you may have lost that child. The introduction of high-dose Septrin, I guess, must have helped. But however, one common thing that many of us don't tend to remember is the infiltration of lymphocytes into the lungs in young babies that have advanced HIV disease, called lymphoid interstitial pneumonia. For one reason or the other, you also took care of that. I guess you gave those steroids thinking you are supporting effective management of pneumocystis jirovecii pneumonia, but that steroid may have actually helped in what we call lympholysis of infiltrated lymphocytes, if this child actually had what we call a LIP. So by and large, the availability in your hospital for intensive care for babies has actually helped out. And I think I want to congratulate you for that facility. However, one thing that we really need to bring out from this presentation is that antenatal care for all women should offer HIV testing. If we had known that this child had a mother that is HIV positive, you would have been following up that child all along, and we will have started cotramoxazole for this child all along. You will have actually carried out PCR tests all along to find out this child is infected, and you might actually have started antiretroviral therapy for this child. You ask a question whether this child has advanced HIV disease. Yes, the answer is yes. The definition of advanced HIV disease in a child or in any child age less than 5 years is presence of HIV infection. If you are HIV infected as a child that is age less than 5 years, your disease is advanced HIV disease. And why? Irrespective of your CD4 cell count, even if the CD4 count is 1,500, you are labeled with the diagnosis of advanced HIV disease. The simple reason is that you have these lymphocytes that are functionally paretic. They are functionally useless. They are not giving you any protection whatsoever. So infection in any child that is age less than 5 years of age is defined as advanced HIV disease. What strategies could have prevented this child from becoming so ill, the only strategy is that make sure that you offer HIV testing to all pregnant women, detect an HIV-exposed child, and start to give the prophylaxis right from birth. What options do you have if this child has low saturations? I guess this child eventually has low saturations. That was why you moved the child to intensive care unit, and you have given the best option, which is the CPAP. You have supported that child with CPAP to be able to navigate himself or herself through the critical period in time where he has very thick secretions that does not allow oxygen to pass from the alveoli into the lung capillaries. I think on the whole, this was a very big kudos to the management team that allowed this four-month-old child to survive. Thank you very much.
Thanks so much, Prof. I think you covered quite a bit, and I think this was again a great case. I sort of echo your appreciation for the management of this child who arrived quite ill. And I think, Prof, you also already had gone through some of the pathophysiology around respiratory distress in an infant. And again, I think this was the pressing issue or the issue of most concern when this child presented at casualty. And this is something that is quite a common picture, I think, in many hospitals where a child comes in respiratory distress. And it is really on us as healthcare workers to manage the respiratory distress, but also understand the underlying cause. And here's again where I think we can use the Stop AIDS mnemonic or the Stop AIDS kind of as a tool to think through what needs to be done. So first and foremost, you stop and you look at your patient, and we see here that we have to screen for what is happening with this child. So even though at the very beginning we do not know for sure the HIV status of this child, we have some idea that some clues just based on the history of the mother presenting late for antenatal care, despite not having an HIV or HIV status is unknown. And so this is where testing the mother first and foremost also gives us an idea that this child is definitely HIV exposed, but may also be HIV infected as well. And so in that sense, once we screen, we also have to sort of think about our screening for HIV as well. And then once we have that suspicion, we know that, again, there are a number of things that may cause pneumonia or difficulty in breathing in young infants. And so to the, in addition to some typical bacterial infections or typical viral infections, we are now thinking to ourselves, well, we also need to screen for and think about those pathogens that are opportunistic and that really affect those that are immunocompromised. And so in this case, I think that the diagnosis of PCP, I think, comes from again, we know that this is very typical in children and young infants. We typically see this between 2 to 6 months of age. It can happen in older infants as well, but we usually see this in an infant, and the presentation was quite classic. We tend to see PCP present as an acute onset in younger infants. And even though we saw findings on the chest x-ray and we heard them on auscultation, sometimes what can happen is you see respiratory distress in the infant. That is, but when you listen to the lungs or when you see the chest ray, it does not seem like it is as severe as the actual respiratory distress. But it's really the respiratory distress, and I think Prof, again, spoke to this, that is what is immediately life-threatening to that child. So again, figuring out, making sure that we are not leaving any diagnosis out. We're treating with broad-spectrum antibiotics, but we also, now having that suspicion of PCP, have started high-dose cotrimoxazole. And again, this is a case where we have to do a little detective work to really understand that that is a huge risk for this child. Just going through the rest of the stop mnemonic. So once we've screened and we've thought through what are the different pathogens that we really have to be concerned about, then we have to treat. And we're treating we're treating with antibiotics as in case we are missing a bacterial infection or in case this is a severe bacterial infection. But we're also starting the treatment for PCP, which is high dose cotrimoxazole, and that's given every 6 hours for 21 days is actually the treatment. So this is different from the prophylaxis dose, but it is a commonly available antibiotic, so should be available. So the O then comes down to optimize, and we think about optimizing treatment. For in this case, for this young child, I would say, or young infant, I would say it's important to think about when this child is, stabilized from a respiratory standpoint, would be able to start ART. And luckily, the ART formulations we now have for this age group are just those dispersible formulations. So the appropriate regimen here would be abacavir with 3-TC, which is available in a dual tablet that's dispersible, as well as dolutegravir, which again we know is a much more potent antiretroviral drug and also much easier to give than what we previously had, which were Kaletra or LPVR-based, lopinavir-ritonavir-based treatment. So again, we have a much easier and much more optimal ARV formulation to give. And I also want to point out here that if we're optimizing treatment, we also have to think about the mother. So we already know now the mother here is HIV, is also living with HIV. And so we need to also start working towards making sure that she is linked to care and treatment as well. And so that optimize is both for optimizing the regimen, but really thinking about the full package of treatment and making sure that that child is linked, and the child and the mother in particular are linked to care. And even if we are recommending starting ART while in the hospital, once that child is stable and able to take medications by mouth, then we would want to start that so that it doesn't get lost after discharge. But even before discharge, we not only want to start ART, but make sure counseling is done and make sure that mother and the child are both linked to the ART center for follow-up. Now, again, we've also gone through the question of, does this child have advanced HIV disease? And absolutely being HIV, HIV positive, although we actually don't know that for now. We know for sure that this child is HIV exposed, but given the severity of illness, given the history, we have a strong suspicion, and we could almost say that this is a presumptive diagnosis of HIV until we have proof otherwise. And in this case, we've sent a PCR. So PCR really is the definitive way of diagnosing HIV in a young infant. And so we've sent that, and whether we have a point of care machine that's in our facility or whether we need to send this out to the laboratory, this is a test that's critical that we follow up on. And so again, this is where follow-up of that test and making sure that we get the result in a timely way is critical so that we establish that diagnosis. Now, lastly, I'm gonna go to the P, which is prevent, and that is once this child has recovered and doing better, we know now that we have a strong suspicion of HIV infection in this child with severe disease, given the presentation of PCP pneumonia. And so we would want to make sure that even after finishing that 21 days of cotrimoxazole, that child continues on cotrimoxazole going forward. And again, we also want to then make sure that we're treating the mom. Just going through one last thing to add here is that when this question about what strategies could have prevented this child from becoming so ill, again, this is coming back to making sure that mothers are receiving adequate antenatal care, are also HIV, are tested for HIV at the beginning of ANC, but also that we are repeat testing following that, particularly in high prevalence settings. So at the, whether it's after delivery or in the first early few weeks, making sure that we repeat testing. But there's little we can do once that infant actually presents to us. And one of the things that I also want to raise here is the fact that this child came in respiratory distress, and over the course of a day, acutely worsened to the point that the child needed mechanical ventilation, which is a very invasive procedure and is not available in every facility. But I want to point out here again, one of the reasons why we consider young infants like this as having advanced HIV disease, if they're HIV positive, is in fact because they are very fragile and vulnerable, and they don't have the same reserves, or they don't have the same stamina that older children and adults have. And so one thing to just add, when you see an infant, a young infant like this, in respiratory distress, is to know that one concern is that if they are in distress, that they will tire out quickly. And if this child was really having difficulty breathing, one thing to suggest is immediately thinking of additional ways to support respirations, whether it's just by blow-by oxygen, which does not provide a lot of extra oxygenation, but just enough that potentially that could help relieve some of the distress. And so just in terms of preventing that acute worsening of respiratory distress, it's important to think about how we support that early on to prevent that tiring out that may have happened. And so I do think it's important in our facilities, especially if we are seeing children who come in with respiratory distress, that we understand what mechanisms or what interventions we have available to us to help support oxygenation, breathing, and respiration. So overall, I think, again, this was a great case. It really illustrated, it was a very sort of textbook example of how we often see PCP pneumonia in young infants. And it was great to see that this child recovered. And again, now, though we have sort of gotten past this initial illness, there is still more to do. We again need to make sure that we are starting the appropriate ART regimen, making sure that the child and the mother are linked to the clinic, and that this child continues on PCP prophylaxis now that we know that this child has, we have a better confirmation just from the clinical history that this was very likely PCP infection. So I'm going to wait and see if there are any questions from the audience. Please feel free to put those in the question and answer box here. And in the meantime, I will also turn over to Bahati to speak more to some of the ongoing issues that this family faces. Thank you.
Thank you, Dr. Nandita. I would just like to also double click on what you said with regards to then optimizing treatment would also mean optimizing the support that we give to this family. Just as Dr. Puri was presenting the case, I thought there's a lot going on for this mom. She has 2 young children. She's just given birth. This child is 4 months old. There's respiratory distress. There's a presumptive HIV diagnosis. She's also dealing with her own HIV diagnosis. All this is happening at the same time. And it's important that whilst we're screening for these pathogens, we're also thinking of screening for mental health. So that is one thing that I think that we can start including in our treatment packages. Where does this mom have postnatal depression? Does she have depressive symptoms? Does she have anxiety? Are there any suicidal ideations? What are her stress levels like, especially in a situation where her young infant is very ill and she's receiving all these diagnoses? The other thing that really struck my mind was around how do we communicate as healthcare workers when we meet somebody and we want to explain PCP, we want to explain an HIV diagnosis. Is our communication understood? Are we matching our information with literacy levels of the people in front of us? Or are we just doing it as a tick box that we have said that, okay, we are thinking that the baby might have HIV, might have PCP, and we move on from there? I think it's quite important for this mom to understand all these investigations, for her to understand the treatment management in a way that is applicable to her, so that when you discharge her out of hospital, she is also a part of the collaborative plan. She understands why she needs to continue this treatment. She understands why it's important for her to be linked to a healthcare facility. She understands why her own support is necessary. So that's just something that made me wonder whether how we explain things, is it just a tick box, or do we really try and cater our communication to the individual needs and the person that is in front of us? Because people have different literacy levels, people are going through different mental health periods. So you may be explaining these things, but if I'm filled with cortisol, stress hormones, I may not hear what you're trying to tell me. So I think that's important for us as healthcare providers to consider. I think another thing to consider is, what are the support networks that we can link this mother to? It's good to link her into care. That's an important aspect. She needs her art. If her child is going to, if we're strongly thinking that this is HIV for her infant, they also need to have art services. But what else? Does she need to be linked to other moms who have babies who are living with HIV? Does she need a space, an individual space, where she can talk about these diagnoses? She can talk about her experiences. Do the other children need testing? She has other children and she hadn't been tested before. Does she need support for thinking about that extra step? Does she need support in terms of her social economic vulnerability? Are there organizations that we can refer her to in order to for her to have some sort of income going on? And if these support services are not available, should we start making noise about this? Because this mom isn't just a mom coming in with a baby with PCP. She has other psychosocial issues that are pertinent to the treating of PCP and to her holistic life. Remember, people are going to be in our care chronically, so we want them to have quality of life that is chronic. So I think our support and treatment need to coexist. They need to be immersed, and these are things that we need to be making noise about if they're not already available in our settings. Thank you, Agnes.
Thank you, Bahati. That was a really nice way to bring the case to a close. I mean, especially those points you raise about family and the mother, and because quite often we're so busy, we're just thinking about that child in front of us when there's a whole world out there that impacts on the child's well-being that we often overlook. So thank you for unpacking that. I don't want to waste time because there's so much on the second case as well. So I will hand back over to Puri, or Puri's recording, to go through the second case, and then we will, I will ask Nandita to give her remarks first, and then Prof, and then Bahati. Thank you.
This girl was diagnosed for HIV in March 2021 at an outpatient clinic, as had lost some weight. Her CD4 was 220. She didn't refer any TB contact, but as she referred lost weight, she was screened for TB. You can see that the X-ray was normal. She collected a sputum for gene spread and culture that came negative. She started on HIV treatment in April 2021, but no tuberculosis preventive treatment was initiated at this. The family background: the child lived with her grandmother. Parents are divorced and they remarried and live with other families. This child is living with the grandmother since she was 5 years old. The grandmother didn't know anything about the mother HIV status. The child presented at the clinic in May 2021, 1 month and a half later, with the complaint of vomiting, severe headaches, and low-grade fever over the past 5 years. He was brought by the grandmother. The grandmother stated the child is not disclosed to HIV, and she's having challenges giving the pills. The grandmother is worried that these pills make her sick. In the physical examination, we can see that the temperature was 37.3, BP 100/68, heart rate 82, respiratory rate 40, normal for her age. He has a normal auscultation of the lung. The abdomen was also normal. And in the neurological examination, we see that the child was oriented, not alteration of consciousness, pupil equal and active, neck stiffness, sensitive to light, were the findings during the neurological examination, and no focal neurologic deficit identified. Because of the clinical presentation and the findings in the neurological examination, the team decided to perform a lumbar puncture. The cerebrospinal fluid, the analysis is shown here. We can see that the child has a high number of lymphocytes, the glucose is low, and the protein is a bit higher. This is compatible with a lymphocytic meningitis. The cryptococcal antigen came negative, and we were lucky as we received the gene spare positive. The child was diagnosed of TB meningitis, probably in a context of IRI. He was admitted on the ward and started on rifampicin, isoniazid, ethambutol, and picillin. And as the child has a meningitis, tuberculosis, we decided to also add a prednisone course. We have vitamins B6, continue with antiretroviral treatment with CDF, TRISTC, and DTG, and add an extra dose of dolutegravir 50 milligrams. And continue with prophylactic. The child condition was clinically improving and was discharged after 10 days of hospitalization. To prepare the discharge, the counselor treats the parent of the child, but the parent says that they don't want to take care of the child. She will be in the hands of the grandmother. Then the counselor had several meetings with the grandmother to correct the misconception. Remember that the grandmother was worried because he thought that the pills made her sick. Educate about HIV, ART adherence, and other pills. Introduce the concept of HIV disclosure to the child, because the child is starting asking questions, why I'm taking these drugs? And also, the counselor engaged with an organization, a community-based organization, and arranged for home visits to support the grandmother to bring the child for follow-up. After sorting out the social situation, the child was discharged, and she's coming weekly to pick up her TB drugs, and she's coming to the ART clinic with her grandmother on time. She's currently on first month of TB treatment. The challenge for this case that we want to highlight is how to diagnose an IRIS. The TB diagnosis, that is not always easy. We were lucky that the result came positive. The adherence with multiple pill burden, and the caregiver age. A question for our expert. Would you stop ART when the child was diagnosed with TB? Does this patient have an IRIS? And the last question, what strategy could have prevented this child from becoming so ill? Thank you very much.
Thank you, Puri, for that case. And again, another successful case that really showed, the benefits of using kind of that stop, sort of, again, the stop sort of strategy to screen and then treat, optimize HIV care and treatment, and then prevent further illness. So in this case, unlike the previous case, in this young girl at 11 years old, she's coming to us with a known diagnosis of HIV. So she's already been on ART for a couple of months, for at least a month, and presenting with some new signs and symptoms. And I believe at the time we also had the CD4 count that had been done when she was first diagnosed. So first and foremost, I'd have to say that this is one case where we know the diagnosis, we know to suspect some infections that may be particular to children living with HIV who have advanced HIV disease. Now, so the first step is screening. And here I think, again, we know she's presenting with meningeal irritation, so that sign of a slightly stiff neck, but we don't hear or we don't see any signs of severe intracranial swelling or pressure, because that's one of the worries that we would have, particularly with things like cryptococcal meningitis. But here we're very lucky that we also have the cryptococcal antigen test to send, because this is, we don't see cryptococcal meningitis as often in younger children, but we start to see it in adolescents. And so in this case, we were able to send the cryptococcal antigen and know that it was negative. We also were able to do a lumbar puncture. And I know this is one of those procedures that people can be very hesitant, but in this case, it really helped us establish the diagnosis. So a lumbar puncture, again, helps us to look at the fluid that surrounds the brain and gives us a sense of what kind of infection may be present. So here we saw that we actually had the analysis of the CSF, or the cerebrospinal fluid, that showed that there were a high proportion of lymphocytes, which we shouldn't see, right? So we normally expect CSF to be clear with no cells in it. And if anything, sometimes we have a bloody tap and we have red blood cells. But when we see such a high proportion of white blood cells, particularly lymphocytes, and added to that a high protein level in the CSF, we have a sense that this could be TB. Because again, this is very typical of what we see in TB meningitis. Now, added to that, we also have the GeneXpert test that came back positive. And so again, now we have two sort of ways of better understanding or better making out what this diagnosis is, and understanding that this is this could be TB meningitis, or this is very likely TB meningitis. So the more evidence builds about a particular diagnosis, the more confident we can be of what we are treating for. And so the treatment here for TB meningitis, as many of you know, is a 4-drug regimen for 12 months. And so it started there in the hospital, and we can see that she's improved. She's also been given a dose of steroids. Now, this is part because we want to prevent, or we are concerned, because she had recently started ART while having a TB infection, we worry that there's an inflammatory response. So as the immune system starts to recover, it can cause an inflammatory response, which we call IRIS. And so the steroids are really there to reduce that inflammation. We sometimes give them in TB meningitis as we start therapy as well, again, to reduce inflammation and prevent brain swelling or prevent ongoing inflammation. So and a couple other things that help us to know that this could have been an IRIS-like situation is just having the history, right? So having the history that she had been diagnosed, also having that history that she had a low CD4 count and had severe immunosuppression, And then lastly, the time of presentation, that this occurred a month or so after starting treatment. And again, that's typically the course of an iris like reaction after starting ART. So again, I want to just again think that back through our stop stop strategy. So first and foremost, we did this screening. So she came in knowing we knew her status and her history, but by screening, by doing the lumbar puncture, by doing those laboratory exams, in addition to a good thorough physical exam, we can make out that this is very likely a diagnosis of TB meningitis. And then the next would be then treating the TB meningitis, starting that immediately along with a dose of steroids to decrease inflammation. But we know that that TB treatment really needs to continue for 3 months, with 2 months of an intensive phase and followed by 10 months of a sort of maintenance phase with RH. Now there are shortened courses with different drugs for TB meningitis. However, those shorter courses have not really been used or studied well in children living with HIV. So at this time, we still recommend 12 months of treatment after TB meningitis. And as to the question of whether or not her ART should have been stopped at the time. Now, this is actually a tricky question because so much of it depends on the course of the patient. In general, once a patient has started ART, if they develop an iris and an overwhelming inflammation that is life-threatening, then at those times, it may be wise to hold ARVs for some time. However, in this case, we gave her steroids, as well as it sounds like over those few days, she started to improve and respond. So to me, it's a question of whether or not her ART really should have stopped. Now, if she had not been on ART, or if her ART had been held previously and she had started TB meningitis, this is the one condition where we sometimes wait a little bit before initiating or reinitiating ART. So we wait anywhere between 4 to 8 weeks to make sure, again, that we've started to manage that TB infection, started to treat that TB infection before, again, bringing back the immune response. And that said, so this is, again, a delicate balance between making sure that child does not interrupt treatment and that we give her as much time to build back her immunity, and balancing that against the risk of further inflammation. So some of it really depends on her clinical course, how the severity of her illness, and how she is responding to our initial treatment. And so once we've said, at least we've started to treat TB again with the 4-drug regimen, we then also have to remember that we have to optimize her treatment. So again, she's already linked to an ART clinic, and she's linked to an ART clinic already. We want to make sure that we correct any misunderstandings about the reason for her illness, so that the family does not blame the ARVs. But we also know now that she has taken a TB treatment with rifampicin, that we need to dose her sort of adjust her dosing of dolutegravir. And again, this is much easier than the previous drugs we used to have. So now at this, she can take 1 pill of TLD, being over 20 kilos, but we can add a second dose of dolutegravir, 50 milligrams, 12 hours after that dose. So she would be taking it twice a day with her TLD in the morning and the dolutegravir in the evening. We also have to then consider her pill burden, right? Because she will, on top of that, be taking TB medication. And then if we go back down to the P, which is prevent, we also know she has severe immunosuppression and should be on cotrimoxazole prophylaxis. Now, does she need fluconazole prophylaxis? Luckily, we again have a cryptococcal antigen that is negative. So that is one less thing. But hopefully, again, I'll say that this was a successfully treated case, and it sounds like the right things were done here. And again, what we need to do now is make sure that we maintain this child in care and make sure we continue to optimize her care and treatment. And with that, Prof, if you have additional suggestions, please go ahead and add in.
Thank you very much. I'd like to address question number 2 first. Does this patient have an iris? The answer is yes. Iris means immune reconstitution inflammatory syndrome. It happens when you have started an individual on antiretroviral regimen that allows the immune cells of this individual to wake up. What this individual had initially is large quantity of what I will refer to as tuberculous antigens. And of course, you have not cleared all the tuberculous antigens with the anti-TB regimen. By the time the immune cells of this individual completely wake up. Before she started antiretroviral therapy, immunity was low, and what could set up an inflammatory reaction requires functional immunity. That functional immunity was not there. The use of DTG-containing regimen in this girl wakes up our immunity. And by the time immune functions are returned, it still has large quantity of TB antigen in a system. So you have a situation of TB high risk. It could also have been cryptococcal high risk, could be any form of high, but in this instance, we are very sure this individual had a TB high risk. To make a diagnosis of an iris, you require that that individual had initially a low CD4 cell count and a high viral load. And then you have started this individual on antiretroviral therapy, the low CD4 cell count dump up to the sky and the viral load sink very fast. If you have these two, then you know, and then the individual becomes ill, you know that that illness is typically high risk. But in this case, we didn't have that story of very low CD4 cell count, or we had a low CD4 cell count as low as 220, but the new CD4 cell count that is supposed to be recorded to be about 500 or 800, we didn't see it here. We didn't see initial very high viral load, which sinks. To make a diagnosis of high risk, these are the requirements. Very low CD4 cell count before ARV, and very high viral load before ARV, and then of course you have started ARV, you see the CD4 cell count rising through the roof, and you see the viral load sinking, and you now see the individual becoming more ill. But from clinical suspicion, there is no doubt in my mind that this particular child has an iris. Now, to question number 1, will you stop ART when this child was diagnosed with TB? Yes, like Nadita said, when you have started an individual on ART, the general teaching is that you don't want to stop again. But you could have delayed the initiation of ART if you had an idea that this patient is presenting with a scenario that could be complicated with iris. And what is the scenario that could be complicated with iris? You have access to pre or baseline CD4 cell count is low. WHO tells you that when baseline CD4 count is below 200 in an adult, you should suspect that that adult, if started on very potent antiretroviral therapy, will be complicated with high risk. So you should have, and that is linked to the question number 3, what strategies could have prevented this child from becoming ill? If you had an access to properly evaluate this child at the beginning, that this child had a low CD4 cell count defined by WHO as CD4 less than 200, but this child has a CD4 cell of 220. That is where we have to be thinking out of the box now. If he had had a CD4 of less than 200, the teaching is that you should not start that child on antiretroviral therapy. You should suspect that he may be harboring any of the 5 killer diseases that will precipitate iris if you start that individual on antiretroviral therapy. What are those 5 killer diseases? Number 1 is the TB, which she presented with. Number 2 is cryptococcal infection or cryptococcal meningitis. Number 3 is toxoplasmosis. Number 4 is pneumocystis jirovecii pneumonia, and of course, you can also present with sepsis. These are the 5 WHO killer diseases which you must screen this individual for before and be sure that any of these diseases are not there. Then you will be allowed to start antiretroviral therapy in this individual. But this individual was not screened for any of these 5 diseases. He started antiretroviral therapy. There's no doubt in my mind that the immunity that we think was fine because CD4 was above 200 was actually not fine. And that actually is a situation where we begin to think out of the box. Must we always go with guideline very strictly? Because the guideline states that when CD4 is below 200, these are the extra things you must do before you start antiretroviral therapy. And this individual has 201, 220, 210. You think there's no need for you to expect that his treatment may be complicated with an iris. I think this one single case that one will begin to see how many of these type of cases are out there that we start the patient on antiretroviral therapy at CD4 of 220, 240, 250, 260, even 300, and are complicated with iris. When the guideline states that we don't expect high-risk complication if the CD4 is below 200. This is one good take-home point here. When we have our patient presenting with fairly low CD4 I think the good practice would be that please still suspect that this individual may harbor killer infectious diseases that may precipitate high risk in these people when you initiate them on antiretroviral therapy. I would like to stop there. Thank you.
Thank you, Prof. We have an 11-year-old who is ill. She's experiencing TB symptoms. We also have an 11-year-old who has been separated from her primary family. Both mom and dad have remarried, and she has been left with her grandmother. We have an 11-year-old who might be who is experiencing neglect from her parents. We also have an 11-year-old who has probably stopped going to school if she's in school because she's unwell. We don't know what physical changes have been happening to her. And with illness sometimes comes with bullying and teasing. So there's a possibility of all these things happening in the midst of this TB diagnosis, and she's asking questions around why she's taking pills. I'm just trying to drive across that it is not just the clinical presentation that we need to be looking at. Have we inquired on what her relationship is like with her grandmother? Does her grandmother, who's now her primary caregiver, need support? Are there any adverse childhood events that she has experienced, such as being separated from her mom and dad, that will later on affect her? Because as we know that children who experience adverse childhood experiences are at more risk of poor health outcomes. So this is not something that we can take lightly, because it's going to still come up in their clinical management. So it's just, again, emphasizing the need that our counseling needs to move beyond art. It needs to move beyond telling somebody that they're living with HIV. It needs to start looking at the person holistically. We are not just treating HIV, we're treating a whole person who has different aspects in their lives, like their spiritual beliefs. Did the grandmother have any spiritual beliefs that made her think that this lumbar puncture or this treatment wasn't good? What is going on within her environment that will need support? What is going on in terms of her social circumstances? What is going on in terms of her mental processes? How is she processing this illness? Is that something that we're asking the child even? Is that something that we're asking the family? And so really reiterating that our counseling should not just focus on explaining what a viral load is. Counseling isn't just explaining that we're taking art at this time and daily and consistently. We need to really look at people holistically and focus our counseling in that aspect. And now moving on beyond, what sort of support systems would we have for this young girl when she is told that, okay, you're living with HIV and this is what this means? I think it's essential that the healthcare workers are trained in post-disclosure support, that we shouldn't just take it as an automatic role that people should just do just because they're clinicians or the doctor, but we should train our clinicians in how do we effectively and with empathy from a rights-based approach tell people about their diagnosis and support them. And support, again, not just being come to the clinic to receive your art, but what else is going on with your mental health? What else is going on in terms of your psychosocial needs that we can help you as healthcare workers? So again, I'm going to sound like a broken record. Let's look at our counseling, let's look at our support from a holistic manner and not just the actual biomedical diagnosis. Thank you, Agnes.
Thank you, Bahati. I think you can continue sounding like a broken record because we do need that. We do need to keep hearing that. I'm wondering if any of the panelists, three of you, if there's anything you would like to come back on that you want before we move to our closing remarks. Any other? I see that we had one person that's been answered in the Q&A. Yeah, so the floor is still open for you if you would like to give any more remarks.
Okay, thank you, Rona. Just one comment on case 1. There was the question whether you should wait for DNA PCR result for that child before we initiate antiretroviral therapy. I'm sure Nadita dwelt a lot on it, but the straightforward answer in this instance is that we should start that baby based on empirical diagnosis of HIV infection. We have sufficient information to assume that that baby is HIV infected. The mother is HIV infected, and he has HIV or AIDS-related type of infections. So actually, took him or her into intensive care unit. So the point one, what we stand to gain is much more than what we stand to lose if we start that individual on antiretroviral therapy. Starting the baby on antiretroviral therapy and finding out that the person is negative, we have lost nothing. But if you start antiretroviral therapy and later we prove that he has HIV infection, we have gained a lot. Gaining a lot in the sense that the HIV that you see is archiving into sanctuary sites. And the earlier we begin to bring down the number of viruses in the circulation, the less the number of the virus that are archived in the sanctuary site, the likelihood of that child developing neuro AIDS is much lower if you start the antiretroviral therapy quite early, because part of the sanctuary site is the neuroglia, of the glial cells in the brain. The likelihood of those viruses, infiltrating and occupying all the corpuscles in the liver is also reduced. You will have very minimal amount of sanctuary HIV infection. And the likelihood, sometimes starting HIV treatment early in children, sometimes may amount to what we can call acute HIV treatment. Acute HIV treatment means that before most of the viruses are moved into sanctuary site, you have cleared the viruses. And the likelihood of what we call functional cure, the type they describe for Mississippi baby, is quite common in children. I have actually had an opportunity of clearing HIV infections in a number of our children to the extent that they achieved what we could call seroreversion. These children were infected. Eventually, at 18 months, they were shown to be HIV antibody positive. And after about 2 or 3 years of follow, all of them are now testing HIV antibody positive. And they were now querying, did you really make a diagnosis before? The truth of the matter is that when you start ART early, very early, you are likely going to clear the virus from the circulation. And of course, you will stop stimulating. You will not have sufficient amount of viral antigens that will keep stimulating immune cells to produce corresponding antibody. So the likelihood of seroreversion is there. We have a lot of things to gain if you start that baby on antiviral therapy. If your system is so good at turnaround time, it's not like my system where turnaround time for viral with DNA PCR is like 1 month, 2 months. I cannot wait for 1 month, 2 months. If I have a child like this, I have sufficient clinical information to suggest that I'm dealing with HIV infection from this child, and I will start the patient, I will start that baby on antiviral therapy moving forward. That's the comment I have for case 1. Now, for case 2, I think I also want to just share a little information on the use of lumbar puncture in making diagnosis of HIV-associated infections. Because when an individual, particularly when you have an individual like this 11-year-old girl, the main problem he came up with 2 or 3 months after he was started on antiviral therapy was headache. She was having headache. And maybe she also has some features of meningeal irritation, vomiting. But that is one of the, and of course, he didn't go far to be having diplopia. But the major thing that he actually presented with is headache. Headache in an individual that is HIV infected, you must exclude 3 or 4 things. Number 1, you must exclude tuberculoma, which in fact this girl has. Or you must also exclude cryptococoma, that's cryptococcal meningitis, which I'm happy they were able to exclude in this child. You must also exclude what we call cerebral toxoplasmosis. These are the 3 major killer diseases in this individual. Very good that you are able to do, I think you did what we call blood or serum crack test, which is fine. In places where you have capacity to do lumbar puncture the way it has been done here, I think you should maximize your capacity of being able to do lumbar puncture. Not many people have the skill to do lumbar puncture. So if you have the skill to do lumbar puncture, you must maximize the utility of that lumbar puncture. Number 1 thing is that you have done the thing not only to do CSF protein, CSL cytology, you must also use that to also confirm that the TB is there by using what you call CDA, or you must also do what you call CSF crack. But most importantly, you should plan also to use that capacity to do what we call therapeutic lumbar puncture, in the sense that if it were to be critical meningitis, you are doing LP not only to make a diagnosis, you are doing LP to treat the individual, because until the raised intracranial pressure is brought down, and you may have to do this LP 2, 3, 4 times before you are able to bring down the raised intracranial pressure to normal level. So what I didn't see us describe here, which I want to draw our attention to, that whenever you do lumbar puncture, you must always take what we call opening pressure. Just use a manometer. It will tell you the normal intracranial pressure should be less than 20 cm of water. And by the time you are getting 25, 30, 40, 60, that individual is in sheer trouble. And you have to bring that pressure down. And as a system of bringing it down gradually, that will require several LP. So sometimes they will say there's no manometer. Well, some best practices is that you can also use, you can connect what you call your infusion tube to your LP needle, and you can just raise it up and use ruler to measure the level of CSF that rises in that tube. So these are the things that are practical that we can do. So I'm very happy that in your institution, Dr. Puri, you are able to offer these services. Not many institutions where I practice were able to offer these services. You will hear that we are inviting anesthetist, we are inviting the neurologist to come and help us do a lumbar puncture where you suspect that individual that's HIV infected has a headache. So headache in this individual, you must exclude tuberculoma. I'm happy you are able to exclude it and that you are able to make the diagnosis. You must exclude cryptococcal meningitis. You must exclude cerebral toxoplasmosis. And in rare cases, if you are in the elderly people, you should also be thinking, but you will not be able to make that diagnosis except a biopsy is done. That we call CNS lymphoma. Those are the differential diagnosis of headache in an individual that is immunocompromised. I just say I should chip this in so that we can add more information, for all our audience. Thank you so much.
Fantastic. Thank you, Prof. So I'm gonna come back to you panelists and ask just before we close, if there is one lesson that you think each health provider should take away from this webinar, please can you come in and just and I'll start with Bahati perhaps, but I think your message is loud and clear, Bahati, but I'll give you an opportunity to repeat it because I think it's very, very important. And then I'll ask Prof to come in, and then Nandita, if you could give the last closing remark, and then I'll come in with my own closing remarks after that. And before we do that, sorry, before you come in, I've just received an announcement to just remind everyone that our closing session is scheduled for 3:45, which is about just over nearly 20 minutes from now. So this is 4:45 South African time. We know it's late for East African time, but we really, really hope that you can stay a little bit longer. We just really would like to appreciate everyone and have a great closing session. So 3:45, we will reconvene for the closing session. But in the meantime, I will hand back over to the panelists. Bahati, your one key takeaway lesson.
Thank you, Agnes. And just again, to really emphasize that holistic care is not a luxury. It's a fundamental human right that we need to be offering the people who are presenting to care. It's in line with our SDGs for all ages. And we need to start thinking of comprehensive care as a standard package. And if it is not a standard package, let's start making noise about it. Let's try and lobby and advocate, not just to the big policymakers, but even within the different teams and organizations that we're working in, to not take comprehensive care as a luxury, but as a standard package. The person presenting with TB or the person presenting with meningitis is still that person who might need a mental health screen, or who's gone through trauma, or who has some kind of socioeconomic vulnerability that needs support, and that is going to affect or impact clinical management. So holistic care isn't a luxury. It's something that we need to be really emphasizing and a standard practice. Thanks, Agnes.
Excellent. Thanks, Bahati. Prof, a very quick takeaway message for health providers.
Just two takeaway messages.
I said what?
One for the case one. Please, we must emphasize the fact that we don't want to be seeing pediatric HIV infection again. There must be no vertical transmission of HIV again. So all mothers must have HIV tests done, and measures are provided that the child does not collect the virus from the mother. This case one shouldn't have occurred if PMTCT is still a program is still being implemented, in our facilities. That is one takeaway point. The other two takeaway points is that case number two, I want to remind us that the WHO criteria to diagnose advanced HIV disease at CD4 second less than 200, I think we should be able to think out of box. When an individual comes with low CD4 second, even if it's above 200, I think if we decide to go strictly by number, you should follow up the patient so that if any, because that child, that individual was saying, taking the ARV, make me sick. He was already developing features of high risk when he was not able to tolerate those stuff. And if I were, I would be thinking that, look, something may not be fitting well here. So this definition of 200, I think is just a guidance, should not take away our clinical acumen. Thank you very much.
Thanks, Prof. And I think Prof. and Bahati has sort of really captured some of the key points from this. I'll add, absolutely, like I think the definition of AHD, let's remember that this is really about identifying those in our care who have severe immunosuppression, whether that is indicated by a low CD4 count or by what we used to call WHO clinical staging. And so in this case, absolutely with a diagnosis of TB meningitis. I think, speaking of holistic care and the full package of care, I think, again, the previous speakers have sort of called it out, is that what we are seeing doesn't have to happen. We have the tools in our hands to both prevent new pediatric infections or new vertical transmissions by making sure that mothers are receiving appropriate care in antenatal and postnatal care services. And also, even for those infants who do acquire HIV infection, whether in utero, during delivery, or through breastfeeding, that we have the tools we need to treat them as well. We have optimal treatment at this point. We have optimal ARVs for infants that are strong drugs, that are safe, and are very efficacious against the HIV virus. We also know that they're much easier to tolerate and much easier to administer than previous drugs. So I'll say the tools are really in our hands. And when we do see a child that we are worried, or we know that this child fits the definition of AHD, that child needs additional care. And I hope here this is where the STOP AIDS package comes into play, where we can really use that as a tool to remind ourselves to make sure we go through everything and provide that full package of care for our patients. And so with that, I'm just going to thank everyone and for those cases. They really were fantastic to learn from, and I think illustrated some important points about the management of pediatric AHD. And thank you all for listening. Thank you.
Thank you, Nandita, and a huge thank you to all of you, our panelists. And I hear your takeaways. I hear all the learnings that we've heard today. They really have been great cases, and so much for us to learn from that. I think that my takeaway lesson is that the Stop AIDS toolkit is clear, and it provides a robust guide and framework for us to be able to implement on the front line. What I heard is that as health providers, we need to be better at history taking so we can make the right diagnosis and make it timely. But I have to say, there's a lot of onus that's being put on the health providers. We must do this, we must do that, but there's also a lot that we need. And so for me, this but is for implementing partners, ministries of health, policymakers, whoever has the powers in the audience, that we also have many needs for us to be able to apply the guidance and to make sure that no child dies of HIV or AIDS today. So we need training. We need the right diagnostic tools and access to laboratories. I hear you all, say we must do lumbar puncture, we must do this, but do we have all the technologies to be able to do that? I hear you, Nandita, about drugs, but is there access and equity to those drugs? So we need the right medication that is palatable for children, and we need equity and access to those drugs. We also need to make sure that caregivers are cared for so they are better able to support children. Yes, that's our responsibility. But then lastly, the most important thing, we also need to be supported and appreciated so we can be a true face of care for our children and adolescents. On that, I would like to thank you to my huge thank you to Dr. Puri for presenting the cases. A huge thank you to Dr. Frigatti in her absence for preparing such great cases for us. And then to you, my three panelists, amazing, amazing. I've had lots of messages on my WhatsApp from Team Pata, from health providers on our WhatsApp group, saying that these are such amazing cases, such great learning. So hopefully we'll be able to do more of this in the new year. But huge thank you to everyone. And thank you to our tech team and everyone who's supported with preparing for this webinar. Thank you.